morning, everyone. Almost afternoon. My name is Rob Pace. It's a pleasure to be here, and it's a pleasure to see so many people, some of whom I've seen in clinic, and many of whom I hope to get the chance to meet at some point in the future. We got a lot of great questions that we've just been sifting through. We apologize if there are any questions that we're not able to get to. And many of the questions were asked several times, and we want to start with some of those. I think it's only appropriate that we start the first question off with the one that was asked the most. And
I'm sorry to interrupt you, Dr. Pace, but I was instructed to make one quick announcement before we actually launched into questions. If you could bear with me. Is that okay?
Dr. Irani's going to make a quick announcement.
So a number of people wrote on their cards about questions related to the presentations that were given this morning and asking about whether the material that was presented would be available in the future. And the answer is yes. And so Carol Gregory has instructed me to tell everyone that the material will be posted on the neurology website. Is that right, Carol? And also on YouTube. Is that right? So I believe we're being videotaped, and there may be a YouTube presentation available. So you'll be able to get access to the information you heard about if you have other questions or things you wanted to follow up on in that regard.
You're going to be famous.
Yeah, right. The other thing I was asked to remind people of is in your packet, we've provided you with an evaluation form for the morning's presentation, and we would greatly value your feedback on the presentations and the formats that we've selected. We want to hear from you about what you thought worked well. We also want to hear from you about things that we can improve on. So please take a few minutes to fill out your evaluation form. I think Carol and Joanne have a box up at the registration desk where we'll be collecting them. That information will be collated, and we're going to use it to try to improve our presentation for next year. So that's another feedback that we'd like to get from you. So take a few minutes for that. Now we're going to, and then that's right. The last reminder, Carol's flagging me from the back, is please turn in your name tag when you're done. We'd like to recycle those, and so she's going to have a basket or something where we're going to be collecting name tags on the way out. So, thank you. Sorry, Dr. Pace.
No problem at all. First question is the most frequently asked question, and it appropriately is going to go to our fearless leader. I've been waiting for several months to be able to put my boss on the spot. I'll pay for this later. Dr. Siegel, can you tell us a little bit more about the effects of a gluten-free diet or avoiding other allergens in its role in MS?
So the relationship between allergies and multiple sclerosis is not very well defined by clinical studies. As many of you know, people could be gluten intolerant. If you are gluten intolerant, you're said to have celiac disease, and there's a blood test that could be done in order to confirm that diagnosis. If you do have celiac disease, some patients suffer from imbalance. It's believed to be due to the allergic response affecting part of the brain called the cerebellum. That is somewhat controversial, but many people do describe imbalance as an aspect of celiac disease. Some people also think you could get some nerve damage in the extremities from it, but that is not very well confirmed. I don't know of any good evidence that there's a clear relationship between celiac disease and multiple sclerosis. But if you do believe you have a gluten intolerance, and I should have mentioned that gluten is a component of wheat, you could talk to your doctor about getting that test done. And there's nothing wrong with trying a gluten-free diet if you think it would help you, a wheat-free diet.
So just to introduce myself, I'm Jessica Stulk, the other fellow, and Rob and I are going to kind of alternate questions. One of the second most commonly answered asked question was about stem cell therapy, and a lot of people indicated they weren't here last year and would like Dr. Arani to address his thoughts on stem cell therapy and the treatment for multiple sclerosis.
So I think it's safe to say that there's a lot of excitement about the possibility of using cells that are recovered from another source and maybe grown in a petri dish and reinfused into an animal or a patient to try to promote repair. We heard from Kevin about the fact that there's a lot of exciting research at the level of animals, and much progress has been made. The obstacles going from animal studies to human studies are great, and progress is slowly being made in that regard. So there are few clinical trials starting using stem cells in patients with MS. The one that I'm most familiar with uses stem cells that are derived from the bone marrow, so hemopoietic stem cells, and there's been some interest in using these cells reinfused into patients to try to promote regeneration. It's in the very, very earliest stages of investigation. We do not here at the University of Michigan have a stem cell protocol or a stem cell trial active, but other centers in the United States are doing that. So we're just at the very beginning now. And one of the obstacles that we face is we're trying to promote regeneration and repair over a wide area. You saw in the MRI scans the lesions that appear can be in both the brain and the spinal cord. It's not like there's damage in one particular part. So the cells have to get to many locations. We're talking about billions of connections that have to reform, or myelin sheaths that have to be repaired. So the obstacles are huge. So the short answer is it's very much at the beginning here. There's a lot of optimism, but it's probably something that still, I don't know what my colleagues would say. My conservative estimate is we're still 5 or 10 years away from really being able to use stem cells effectively in the clinic in patients. Is that something you'd agree with?
Yes, I would say at least 5
Yeah.
to 10 years. And there are some potential dangers with stem cell therapy that also have to be worked out. There's a proclivity of stem cells to form into tumor cells or cancers. That has to be something that's dealt with. And as Dr. Irani mentioned, getting the stem cells to the right location is another big hurdle, particularly in multiple sclerosis, where you can't just inject stem cells into one particular region because there are multiple plaques scattered throughout the brain and spinal cord. So there are a lot of issues, but we're very supportive of investigations in stem cells, and are hopeful it will evolve into a treatment one day. But I agree, it's in its infancy.
You have a couple of questions that we'll direct at Dr. Chad that involve rehab modalities. One, is there a benefit to electrical stimulation to improve muscle and mobility? And two, do you know of benefit, and can you talk about the benefit of acupuncture therapy?
Well, I'll address the second one first because it's a much shorter answer. I can't point to any clinical trials with acupuncture that have shown proven benefit, but at the same time, a lot of people report improvement in a variety of subjective symptoms or objective symptoms, whether it's spasticity or in particular pain with acupuncture. So with MS, there can be a couple different types of pain that we commonly deal with. One is neuropathic pain that's generated in the damaged areas of the nervous system. That has been studied and some good response with acupuncture. And then also more musculoskeletal pain that results from the physical impairments in the muscles, joint pathologies that can result with MS. But for the first question, the electrical stimulation, yes, that can be quite effective for a couple of different uses, again, primarily. For muscle strengthening, the electrical stimulation can be most effective as a adjunctive modality to build strength in a muscle. So in a muscle that has voluntary firing or contraction, but weak muscle contraction, the electrical stimulation can help augment that voluntary strength and improve it. In a muscle that has no voluntary strength or more completely paralyzed muscle, the electrical stimulation wouldn't necessarily improve someone's voluntary strength, but there is still some work out there that has shown benefits, long-term benefits to having the muscle contraction just from the e-stim, whether or not it translates into a functional use of the muscle with voluntary strength. So getting that muscle fiber to undergo its physiologic contractile actions can have benefits for metabolic health, cholesterol, diabetes. So some uses in that, in that realm with the e-stim. But we do see it being very effective to help with strengthening. Common use might be your ankle dorsiflexion, foot drop. E-stim's used a lot there to help build strength in the muscles involved and can be quite effective. And I just mentioned additionally, besides using the e-stim in therapy as a tool to build strength, there are some products out there to wear an e-stim unit on a daily basis to provide that function. And some people can have good results with that. For other people, it might not be as effective, but it's an option that's out there.
So I'll address the next question to Dr. Braley, and it's, could you explain some of the effect that MS has on mental capacity and cognitive skills?
So the effects of MS and mental capacity and cognitive skills, that's actually quite a complicated question. We do know that many MS patients will report at least some form of cognitive dysfunction, whether it be something that's subtle that only they notice, or something that's more apparent in which family members or even employers can notice this. And it doesn't always seem to correlate with the physical symptoms of multiple sclerosis. We do think that this is, related to the damage that's caused by MS, not only in the white matter of the brain, but also a part of the brain called the cerebral cortex. But it is highly variable, and even though we're getting better at using different tests and tools to evaluate cognition, it's still something that's a work in progress. And we actually are using cognitive measures now as an outcome measure in clinical trials, because we are interested not only in the physical disability with multiple sclerosis, but also the cognitive effects, which has been something that's been largely overlooked for the last several years. I should mention that there are other things that can contribute to cognitive dysfunction as well. And even though we're trying to design better medications to help the MS-related cognition problems, it's also important to talk to your doctor about other factors that can influence cognition. It's not always just the MS itself. Mood disorders, depression, and sleep disorders, especially sleep deprivation, other sleep disorders can also add to the cognitive dysfunction. And actually that's something that we're interested in studying right now. We have a new study enrolling now for cognition and sleep disturbances in multiple sclerosis patients. Does anybody else want to add anything to that?
Yeah, just make one additional comment to that, and in saying that we heard about these various clinical trials that are being done to test therapies in patients with MS. So there are examples where in past clinical trials where patients underwent cognitive tests of memory and thinking speed, whether they were on a new treatment or on a placebo group. And when that was followed over time, it became clear that treating the MS with a disease-modifying therapy was actually able to slow down the progression of cognitive change over time compared to patients who weren't on an active treatment. So I often get asked in the clinic, well, what can I do to treat my forgetfulness on a day-to-day basis? And the answer right now really is, let's try to treat your MS itself as aggressively as possible, because unfortunately we don't yet have specific treatments or interventions that target the memory problem itself. As many people know, there are other neurological diseases that cause memory impairment. Alzheimer's disease is one of them. And even though there are approved medications right now to treat Alzheimer's disease that have been shown to slow the progression, regrettably, they're not that potent. And there's very limited evidence that Alzheimer's medications like Aricept and the like have a beneficial effect in other diseases like MS.
For Dr. Maudreyer, there, over the past few years, have been several oral pills that have become available for multiple sclerosis. Could you compare and contrast these and give a sense of what goes into your decision process about prescribing one?
Great question. Did you ask that question wrong? David, you have a question. Maybe we could. Mm-hmm. So to answer the question, we have 3 oral therapy now. The first drug, fingolimod, was approved 3 years ago. It's based on 3 large pivotal trials, as I mentioned before. One is comparing to active, not placebo, it's Avonex treated arm. It showed great benefit in terms of reducing relapse rate, MRI lesion load, and brain atrophy. I would say based on the relapse rate, it seems to reduce by 55%. It's pretty robust in terms of relapse rate reduction and brain atrophy. But it does come with a cumbersome monitoring. There's a potential side effects of a macular edema because the receptor is also located in your retina, as well as bradycardia. So we have to observe patient in our clinic for the first 6 hours. So later drugs, such as BG12, was just approved in March this year. It becomes easier to use, even though it's twice-a-day dosing. But we don't have a head-to-head comparison of the 3 drugs, Aubagio, fingolimod, and BG12. So even though when the pivotal trial was done, they all based on 2 to 3 large clinical randomized double-blind placebo-controlled phase 3 studies, they all approved based on placebo-controlled study as well as the active comparable, like Dr. Brody mentioned. BG12 was done by comparing to placebo as well as comparing to Copaxone. At least it is not worse than Copaxone. So based on the reduction of relapse rate, they're very similar. In a way, I would say if you have relapsing remitting disease, it's really based on each individual. You may have a response better to one or the other drug. For the reasons yet we don't know, like Dr. Siegel mentioned, biomarker studies, we're trying to predict which patient may respond to which category's drug better or more. So the short answer is, as long as you start disease-modifying treatment early, they seem to have great benefits all early at the diagnosis. So in terms of long-termly, it prevent progression. But bottom line, we don't know which oral drugs would help for progressive patient. So that's in the stage of being tested. So we are moving on to clinical trial with sphingosine-1 phosphate receptor modulator-like agent first because it was first approved in relapsing-remitting MS. So it's understandable this trial is more maturely up running, but I anticipate other drug may be also tested in progressive patient. So stay tuned, and there's other more drug coming on, such as Campath and ocrelizumab. They could, like Dr. Brody mentioned, ocrelizumab is already being tested in progressive MS patient. So there's a lot of hope for many, many MS patients. So sorry about
just
talking
to elaborate a little bit more on that. I mean, the decision when I'm one-on-one with a patient in the clinic about which medication to start is a complicated one. You know, with more choices, there are more variables to think about. My personal approach is that I like to involve the patient in the decision-making process. I mean, after all, it is his or her body that we're trying to manipulate here, and they, I think, have a say in the matter. So, you know, on one hand, the oral medications, as you've heard about, there's 3 of them, have the great advantage of convenience, of easy dosing for patients. There really are a lot of people where self-injection is a major obstacle. The main disadvantage of the oral medications right now is that they're all brand new. I mean, we don't have a long track record using them. The injectable medicines, on the other hand, are less convenient. They're a hassle sometimes. But at the same time, they've been around since the early to mid-1990s, and we really have, 25 years of experience now using them. So it's complicated. There isn't a single algorithm that I use in the clinic to decide what therapy is best for a patient. Sometimes there are situations like, for example, I have a patient that has both MS and psoriasis. So you heard earlier that BG12 or Tecfidera has been used in Europe in a slightly different version to treat psoriasis, so that we thought maybe we would try that therapy, hoping to hit both diseases with one treatment. Gilenya has this issue related to slowing of the heart rate, and sometimes I choose to maybe steer a patient away from that treatment if they have a known cardiac condition. So you have to weigh in lots of variables. It's not something that's really amenable to a flow chart or an algorithm, and it's complicated. So they're individualized decisions.
I would also add that the safety profiles are important, and it always has to be considered in the context of your other medical problems. So like Dr. Irani said, somebody with cardiac problems may not be the best candidate for Gilenya. A woman of childbearing age that wants to plan a family might want to stay away from Aubagio. Someone with a lot of stomach trouble, BG12 may not be the best choice for them. Of course, that we can always discuss this in more detail, but these are things that should be running through your mind when you're choosing a therapy, and something that you should be discussing with your doctor.
So I got a couple questions that I think are best targeted for our nurse practitioner, Carol. And a couple of those questions are, do you know of good home care resources, and do you know of good resources for respite care?
Okay, the best way to find out good care for respite care and good for home care is to find other people that have used this. A good clearinghouse or place to go to start getting this information is the Michigan Multiple Sclerosis Society. They can help some. There is also a group called Area Agency on Aging, and they are done per county. These are the Area Agency on Aging is federally funded, so they have resources available to help get home placement for you. For respite care, there is limited numbers around the state that would provide respite care for either the MS patient, or if the MS patient is the caregiver for another person for that patient. You can go to, there's an organization called Citizens for Better Care. And Citizens for Better Care is a group that goes in and looks at all of the long-term care facilities and can give you a rating for it. So those would be some of the ones to start with. And then equally, if you are in support groups, and you're talking to them in support groups, ask everybody, do your consumer question and ask, have you used this? Did you like this service?
I guess one follow-up comment I would make is that we're really excited to have Carol as part of our clinical team now, and she's a very organized person. So if you're in clinic, if you found a facility or a resource that's worked well for you or your family with regards to respite care or something like that, tell Carol. She'll keep a list, and then we can pass that information on to other patients and family members. So we need your help to bring your experiences to spread to other patients.
I'd also like to add, if you are a veteran, we have an MS specialty clinic at the VA hospital, and there are special benefits, particularly if you are deemed to have MS that's service-connected. That means you had your first symptoms while on active duty or within 7 years of discharge from the armed services, and there are some wonderful benefits, including respite, including physical therapy, and even remodeling homes for handicap issues that are at your disposal. So if you are a veteran, you should contact and you're in the area, you could, throughout the state, we have patients who even come from Indiana, Ohio, et cetera, to our VA clinic.
Question for Dr. Braley. Should patients be supplementing extra vitamin D? Should their family members, particularly their children, or even their young children, also be supplementing vitamin D? And are there other supplements that should either be considered or avoided in patients with multiple sclerosis?
So I'll start with the vitamin D question first. So many of you may know that there are some recent epidemiological studies that have shown that patients who have low vitamin D levels are more likely to develop multiple sclerosis, and we think that this might be related to the geographic location of patients. The further we are from the equator, the less sunlight exposure we get, and we need the sunlight in order to convert vitamin D, and our skin does that, actually. And so there's definitely a link between low vitamin D status and the development of multiple sclerosis. But we know that it's more complicated than that most likely MS is a combination of both genetic and environmental factors, and perhaps the low vitamin D levels might provide some evidence of the environmental trigger. That said, children who have, of patients with I'll start with the kids question first. Kids of parents who have MS or kids with a first-degree relative with multiple sclerosis are thought to be somewhat more genetically susceptible. So in that case, it may be worth talking to the child's or I'm not saying it has to be a little child, but the offspring's physician to see if vitamin D is safe in terms of their other health problems, and if so, supplementing it might be a good idea. In terms of the patient, in terms of the MS, patients who have MS, we usually do recommend supplementing vitamin D. Although most of the studies, the really strong data we have so far suggests the low vitamin D may predispose patients to MS, we do have some early clinical trial data coming in suggesting that taking vitamin D, if you have MS, may improve the course to some extent. I think there's a lot of work that still needs to be done in this area. What we don't know yet is what level to shoot for. So we get patients on supplements, and then we're not quite sure if their blood levels have to be within a certain range. But because vitamin D is good for your bones, and many patients with MS, especially the ones who are immobile, have issues with bone health, we do recommend supplementing it. Now, in terms of the question about other vitamin supplements, I'm not aware of any other specific vitamin supplements that have been shown, at least in rigorous clinical trials, to influence the course of multiple sclerosis.
Yeah, I'll just jump in here for a second as well. So if you're deficient in vitamin B12, you can get neurological symptoms that sometimes look like MS. So I'll check B12 levels in patients as I'm trying to evaluate whether they do or don't have MS, and if they have a low B12 level, that might be something to supplement. But I agree with Dr. Braley that there really aren't other great studies that clarify for providers whether other vitamin supplements are indicated. The other difficult issue that she touched on is how much vitamin D should you take. For for those of you who do take vitamin D, you'll know that the bottle comes with pills that are in units, not milligrams. So a usual adult dose of vitamin D is 1 to 3,000 international units a day. It is actually possible to take too much vitamin D. It requires ingesting a lot of it, but vitamin D is very closely related to calcium metabolism, and if you take too much vitamin D, you can predispose yourself to changes in blood calcium concentrations that can cause problems. So it's not a matter that more is automatically better. So I typically advise my patients, I don't know what my colleagues would say, to somewhere on the order of 2,000 or 3,000 international units a day is a pretty standard adult dose.
Yeah, there are ongoing studies trying to determine the proper dose and to really document its exact effect. But I've seen studies where 10,000 international units were given, or even higher, 12,000, and it appears to be safe. I mean, you have to take a huge amount of vitamin D, but I think Dr. Irani's remarks need to be heard, because you could definitely overdose on it. But within the 1,000 to 5,000 international unit range is where I usually recommend people start.
See you later.
No problem.
Thanks for coming.
To kind of piggyback on that question, we received a couple questions about Dr. Wall's diet, or quote unquote the mitochondrial diet. And Dr. Siegel, do you want to address that, or if there's somebody else on the panel who's familiar with that?
So Dr. Wall's diet actually, I think, capitalizes on things that have been known about MS diet for a while. That vitamin-rich diet is important, the vitamins that you could get from a healthy, balanced diet. It also involves eating a lot of fish because of the omega-3 and omega-8 fatty acids in fish, which for a long time people have helped might ameliorate multiple sclerosis. There is what Dr. Stoke was referring to. Mitochondria are little organelles or little structures in cells that help provide energy. And there's some evidence that there's insufficient energy being produced in the cells that make myelin, and that could contribute to MS. So there are substances which help these energy generators work better. One is called coenzyme Q. And so the Wall diet also recommends increasing your intake of coenzyme Q through eating organ meats, like liver and et cetera. I think that the diet is a very reasonable diet. I advocate a well-balanced diet. The Wall diet advocates leafy vegetables, fruits, fish, organ meats, et cetera, and so forth. I think it's a sensible approach. The whole question about omega-3 and omega-8 fatty acids, which are in fish like salmon, sardines, et cetera, has been bandied around a long time in MS clinics and in MS research. There was a Dr. Swank many years ago who felt that the diets high in fish decreased your risk of MS based on some studies he did in Sweden. And he actually outlined a very rigorous diet, high in fish and low in unsaturated fats, and he claimed that his patients did better. That was never subjected to rigorous trials. There was a recent study of omega-3 and 8 fatty acid supplements that was done, I believe, in Finland, and it didn't show much of an effect on relapse rate or MRI lesions. But a lot of these dietary recommendations make sense for your general health, and I think it is possible that the omega-3 and 8 are beneficial, but that trial wasn't sensitive enough to detect it. So once again, I just advocate a well-balanced diet, lots of fruits and vegetables, fish, omega-3 and omega-8 fatty acid supplements are important. And I think coenzyme Q, there's not a lot of rigorous evidence that it's helpful, but there are supplements you can take, and it is rich in organ meats, as I mentioned.
the only other comment I would make about that is what my colleagues have already said is a lot of these dietary adjustments are also good for your general health. So for example, there was a very large study recently published in the prestigious New England Journal of Medicine about the Mediterranean diet, which is very high in things like olive oils, which shows a significant benefit in favor of the diet from cardiovascular standpoint. So a lot of these things are good for you in general, and I touched briefly on the salt issue. So whether or not they're good for your MS, we may not know, but they may be good for you in general, so it's reasonable to watch what you eat.
We've got about 4 or 5 minutes left. There was a couple of questions about the effects of pregnancy and pregnancy hormones on multiple sclerosis. Dr. Irani, are you able to comment on that?
Sure. So we've known for many years that women who become pregnant who have a pre-existing diagnosis of MS, that the relapses and symptoms of MS tend to go into a relative state of dormancy during pregnancy, and it's likely a result of hormonal changes that come about as a result of the pregnancy. Investigators in the MS field have capitalized on that observation, and there actually are studies now making hormonal manipulations in patients to try to, in a sense, recapitulate the state of pregnancy as a way to suppress disease. So there's a lot of exciting work in this area. I don't think we yet know exactly how to do that, but I think there are things to be learned, and it's an important observation.
If I could just add to that, there is a clinical trial going on right now of an estrogen compound called estriol. Estriol has been used in Europe for many years as an oral contraceptive. It has less side effects than conventional estrogen compounds used for oral contraception in this country. And in a phase 2 study, it looked to be possibly beneficial in decreasing new lesion formation in multiple sclerosis. So right now there is a phase 3 study going on. It's being conducted by Rhonda Voskuil, who's the head of the MS Center at UCLA and a good friend of ours. It's the addition of estriol to Copaxone in women with multiple sclerosis. So we don't know the results of that study yet, but it's something that we're following closely. Sometimes I have patients who are on oral contraception anyway, and or plan to go on an estrogen compound, and I will raise the possibility of considering estriol in consultation with their gynecologist. The dose is a bit higher than what's used in oral contraception. In the trials, it's 8 milligrams a day. So I think that's the most relevant clinical trial right now regarding hormones involved in pregnancy as a therapeutic in multiple sclerosis.
I was going to say, do we want to do one last question, or do we kind of want to have the panel kind of give their final comments? Thoughts, feelings?
We could have one more question. We usually don't do final comments.
Okay, no final comments. All right, I'll do one last question. We had a question about the development of MS and if having Epstein Barr diagnosis as a child increases your risk of developing MS. And I'll direct that to Dr. Maudryer.
Well, actually, Dr. Irani probably is a virologist, but you can wrap up what I know. So as I talked about, there is the nature versus nurture as a trigger of MS. It's not yet identified, and genetic susceptible individual may be exposed early on in certain infection. EB viral infection is so common, and actually 90% of population carry the antibody. So it doesn't necessarily triggers MS unless you're genetically susceptible. So that there is a huge study done by George Ebert's group at UK and has demonstrated the link of EBV and vitamin D receptor. The stories is still developing. It's again pointed out, there's so much unknowns, but we know there's epitope presented on antigen-presenting cells that look like myelin, and EBV may be one of them, and there's other infectious early childhood exposure to other infectious agents maybe also play a role. So it's not the only triggers, if I may add.
So if I could just add to that, I think the most compelling epidemiological evidence suggests that exposure to Epstein Barr virus, which causes infectious mononucleosis as an adult, is a risk factor for MS. Epstein Barr virus exposure as a child, there's not good evidence that it increases your risk of MS. It's if you've, if you haven't had infectious mononucleosis as an adolescent or earlier, when if you are exposed to it later in life, then it may be a risk factor. So, so that concludes our conference. I see a raised hand in the back.
Maybe we could be available after we break up. If you have a question, we can take it on individually with you.
Okay.
So we both have comments here. So I know Noel Rose well, having trained at Johns Hopkins. He's an outstanding expert in autoimmunity, and he's exactly right. There are definitely things that people studying MS can teach people who study diabetes or autoimmune thyroid disease, so we can learn from each other. And so developing networks like this are critically important in understanding these diseases, not to mention issues like you raised about, raising awareness and raising funds to support research and the like, all of which is important. Having said that, not all autoimmune diseases are created equally, and we've learned, unfortunately, the hard way that treatment of one autoimmune disease might make another autoimmune disease appear or get worse. So we work very closely with our colleagues in other departments to study these situations. So, for example, here at the University of Michigan, we have close collaborations with colleagues in the rheumatology clinics who take care of patients that have lupus and rheumatoid arthritis, and also with colleagues in the GI clinic for patients that have Crohn's disease and the like. So many of our patients have more than one autoimmune disease, and it really requires extreme care that your treatment for one disease isn't going to make the other disease worse. So I agree with you that we'd like to speak with one voice, and that's an important goal for the future, but it's a very, very complicated situation. I don't know, Ben, do you have comments on?
I agree with everything you said. We do have close interactions with our colleagues who study other autoimmune diseases. In fact, we recently put together a proposal to establish an autoimmunity center of excellence. I was involved in one of those at the institution I was before. That probably is not going to go through for technical reasons, but we do have strong collaborations. We have joint lecture series sometimes, and we sit on each other's students' committees. So there's a lot that we could learn from other autoimmune diseases about MS and vice versa, and we want to take full advantage of that. Sure.
Okay, thank you very much.
So I'd like to thank all the speakers, the panelists, once again, Carol Gregory and Joanne Naprakowski, but most of all you for helping us in our vision and support.
And then just a reminder to turn in your evaluations. There's a box up front, and then they'll also help with collecting the name tags.